The broadcast is now starting. All attendees are in listen-only mode.
Good morning, everyone, and welcome to our April 21st Safe and Calm webinar. This is Deanna Mitchell with Leading Age Michigan. Today's update may be somewhat brief, and so we may be able to return some of your time this morning based on the number of questions we might get. We do have a few general announcements. We will talk a little bit about advocacy related to the HFA-AFC rules for direct care worker payment. As usual, we'll take a quick look at the numbers, and then we'll move to general guidance and resources. We're going to focus on the travel guidance this morning. So let's start with a few general announcements. First, I am going to be on vacation starting tomorrow, and I will be off through April 30. So if you have questions or needs during that time, please remember to use the Safe and Calm email address for assistance. There are others other than myself, as you know, on that email address. And I also want to remind everyone that we have 3 member listservs, skilled nursing, assisted living, and housing. And in terms of practice and policies, you are all the experts in those areas, and you can use these listservs to communicate and help each other address some of these very confusing issues that have arisen. So we want to remind everyone that that's a good way to communicate and figure out what other facilities are doing. At this point, we're going to be moving to a webinar every other Wednesday, since finally and hopefully the amount of information and guidance coming out has slowed enough to warrant that. We do want to note, however, that we will continue to schedule webinars if something important arises, and if necessary, we will increase our frequency again. So our next scheduled webinar is for May 5th, 2021, and they will continue on Wednesdays at 10 a.m. Again, if you need assistance, please email the Safe and Calm Leading Age Michigan mi.org address. And the other announcement I have here, because it's just so basic and we expected it, is that the HHS director again extended the public health emergency to July 2021. So at this point, we are going to move on to our advocacy section presented by Dalton, our Director for Public Policy.
Good morning, everyone. As you may know, last week, the HFA-AFC direct care reimbursement guidance was released. We sent that out in a number of ways. It is also attached to the webinar today, the guidance and the reimbursement form for any HFA and AFC providers. We acknowledge that it is incredibly restrictive, and we will be having a call with some members on it as well, with Director Hertel of MDHHS and Director Travis of AASA. Just a couple of quick things to note. This slide is kind of a generalized summary. We'll also be going over the guidance in a little more detail on the following slides, so that way everyone has the information in front of them. It does provide eligibility requirements for direct care workers and HFAs and AFCs for a wage increase of $2.25. The reimbursement period matches that of the SNF. That is March 1st to September 30th, 2021. The guidance also established a separate question line for HFAs and AFCs. That would be mdhhs-hfa-covid-payment@michigan.gov. And as I already stated, we'll be hosting a call on Friday with Director Hertel and Director Travis. So what are the eligibility criteria? There's 2 sets. So first, your workers need to be eligible, then you as a provider need to be eligible to make these payments. And this is where the restrictions and the restrictive nature of it kind of start. And you'll notice that by some of the language. I tried to copy the language exactly and then kind of boil it down a little bit so you can see what's actually going on. Firstly, the direct care worker eligibility / employee eligibility. A direct care worker has been defined as staff providing direct hands-on personal care services or direct hands-on supervised personal care during a resident's normal awake hours. So as you can see, the definition itself is fairly open to include most staff in an HFA or an AFC, but it would only be during what would be considered normal awake hours for a resident. And unlike for SNFs, staff licensure is not a factor in this. For providers, this is where we see more restrictions here. Providers are eligible if they had at least one Medicaid resident on a respective day. They are then eligible for reimbursement on those days within that month. The guidance does specifically state that facilities who accept only private pay or only other funding sources are not eligible for the direct care wage pass-through program. There is also no overtime rate for this program. The reimbursement is set at a flat $225 for all hours worked. So as you can see, a HFA or AFC will have to have at least one Medicaid resident for their workers and staff to be eligible for the program. We do intend to address this a little bit with the department on Friday, and also we realize that this is incredibly restrictive, as most HFAs and AFCs do not have a Medicaid resident. What additional costs are eligible for reimbursement? Similar to that in SNF, you'll remember that all employer Medicare and Social Security payments or payroll tax expenses associated with the benefit are eligible for reimbursement. For this program, there are state and federal employer unemployment insurance taxes are not eligible for reimbursement. So you do have a little bit of the other costs associated with the program eligible to be reimbursed to you as a provider. So what is the reimbursement process for HFAs and AFCs? Since it is so uncommon for them to have a Medicaid resident, it's a little different. So first, a HFA or AFC will need to be registered in SGMA to be reimbursed, as that's where the reimbursement is actually going to be processed through. I included links to access SGMA there and the link to create a new account in SGMA right there as well. So you can do that there if you so wish. The providers, HFAs and AFCs, will also have to submit the reimbursement form, which is attached to this webinar, to that email address I provided earlier. That's HFA AFC specific, similar to how a SNF does. It's just a separate form because the hours are calculated a little differently because of those who are eligible. Similar to other employers who pay the wage pass-through payments, you're also required to track all eligible expenses and retain documentation regarding the pass-through, and that includes any paperwork or stuff that says you actually paid the pass-through to the eligible employees when your facility was eligible for those. That's it for me today. We're going to move on to questions since I do have to head out. Today is the start of budget day, so that's pretty exciting.
All right, thank you very much, Dalton. I'm actually not seeing any questions, so we can move forward and I will let you head out to the budget day.
All right, thank you. Take care, everyone.
So we'll move on now and take a quick look at the numbers. As you can see from this CDC graphic, Michigan unfortunately is way out in front of all states in terms of new cases per 100,000 persons. We've listed the next 5 states here in order of transmission. They're also very high ranking, but note that they are really far behind Michigan, sadly. This is another CDC graphic that identifies the new cases per 100,000 persons over the entire time of the pandemic. This compares Michigan to the 5 other Region 5 states, and you can see that not only are we surging significantly again, you can see us in the green, but we have pretty much reached the November-December peak that we incurred during the winter. These are the county level incident rates on the left. This is also a CDC map. The map on the right compares changes over the week through April 17, but looking at the left side, you can see that Michigan really sticks out in terms of the cases in almost all of its counties. It's rather dramatic. And this map, also on the left, shows the impact of the current caseload in Michigan. This is the number of hospital admissions for COVID positive persons per 100 hospital beds. And again, Michigan is obviously struggling to provide medical care, and many of our hospitals are significantly overloaded again. Taking a brief look at vaccinations, apparently the CDC has changed some of the graphics that it provides for this, so we don't have the pictures that we did before, but across the nation, about 40% of the adult population has received at least one dose of the vaccine. And for persons over age 65, it goes to over 80%. Those are really good numbers. In Michigan, about 31% of all adults have been vaccinated with at least one dose. And we do note that under the Pharmacy Partnership Program, all SNF clinics have been completed, but there are still some other long-term residential settings that still have some second and third clinics scheduled. Here's our overall routine caseload map for Michigan, again, using that 7-day rolling average. The numbers as of Monday are very close to hitting the 2020 winter peak that we talked about earlier that occurred, in mid-November to mid-December. The death rate, although it is rising again, is not moving at quite the same level. And we think that might be due to the fact that the affected COVID population right now is younger. But many of these younger 40s and 50-year-olds are very ill, and they are filling up the hospitals, as we've noted before. This is the distribution of the CMS county positivity rates for Michigan. You can see that we've updated the format for this chart to better demonstrate the changes week to week. Consistent with the other data we've looked at this morning, you can see that the red level counties have reached the same number as in early December. And that's important because those red counties, remember, do impact the staff testing schedules, at least for nursing homes. Last week, when we took a look at the long-term care data, the state issued an announcement that some of the long-term care data numbers were wrong and that some had been inflated. So they have reissued the past 2 weeks of data. So we've tried to adjust the recent data, but it was really a bit hard to figure out some of the changes. At least it looks like resident caseload numbers continue to be stable, actually in at least 2 of the 3 settings, and especially for SNFs here, as you can see from this graphic. Not quite as low as a few weeks ago, or actually that's a couple months ago, but still very low and very stable. For HFAs here, you can see a small rise in caseload. Again, not quite as low as a couple months ago, but still very low, pretty stable. We did, however, see a bump in the number of new cases in AFCs. So that might bear some watching. And this might be due to the fact that not all residents have yet been fully vaccinated in those settings. So we're monitoring that closely. And for long-term care, here's the table that shows the overall numbers for the past week. And again, you can see that the resident cases are pretty low in general. But the staff numbers of infections continue to be pretty significant, with over 450 new cases during the past reported week. So that's still an issue. So at this point, we're going to move on to the travel guidance. And I have to warn you that in all of our discussions and conversations with the state through this pandemic, this has been probably the messiest conversation and discussion and lacked clarity throughout during the process. So we're going to spend some time talking about this. The issue of safety precautions for staff travel first came up in the recent weeks when CMS issued its updated visitation guidance on May 16th. And in its narrative, and we copied that narrative here, they reiterated that visitation continued to be restricted for anyone in quarantine until they met the criteria to be removed from quarantine. However, they also linked that definition of quarantine to a guidance from the CDC. And the CDC had updated who needed to be quarantined. And that link is there if you want to look at it. So when we reviewed that CDC update, we noted, and I can remember saying this during a Safe and Calm webinar probably about a month ago, that staff needed to continue to follow the CDC recommendations for travel and quarantine. And at that time, someone asked what the travel requirements were, and to be honest, I did not remember. It had been so long since we talked about restrictions following travel that I had thought that it was mostly about ensuring that facilities screen staff who may have been traveling back from a high transmission area and making adjustments based on that risk. But as people began to ask about that and we started to look into it, we noted that CDC also changed its guidance. And that was after the visitation guidance came out. So on April 2nd, the CDC also happened to update the travel guidance. So we reviewed this new guidance and in alignment with leading age nationals discussions with the CDC, we identified that the new guidance did pertain to SNFs and also that unvaccinated long-term care facility staff would have to quarantine following all domestic travel for 14 days because they were working with high-risk residents. And we provided, obviously, this information to our members. So obviously, applying this new recommendation would stress everyone immensely, and we received a lot of questions and concerns about that. So we reached out to MDHHS because we know that MDHHS can also issue guidance, and the CDC guidance does also recommend that we follow the state rules. So we reached out to MDHHS through the IPRAD team about these travel recommendations for long-term care staff, and this is pretty much the response we received. They stated they did update their travel guidance, which would be applied to staff. That guidance is in alignment with the CDC guidance, and in Michigan, we would also have to quarantine unvaccinated staff for 14 days because they do work with high-risk persons. And although we asked for a definition of domestic travel, they really didn't give us one very well. So you can move to the next slide, Blake. So we published that information. And then we started hearing from members in some health departments, one of them actually saying that the facility can choose to use a 7-day quarantine, but does not have to enforce it if it's a staffing issue, and that the MDHH order was not an enforceable order. So more confusion. The state saying one thing, the local health department saying another. So we reached back out to the department again with a question about conflicting guidance. And that was not only about this, but we also were hearing conflicting guidance about the visitation restrictions in at least one county. And we actually did not get a response to this email until yesterday, but I followed up with other people at the state. So since, you can move on, Blake. So since we had not heard back by the 15th of April to this, I recontacted the state and the IPRES and MDHHS responded, as we noted here, that facilities need to follow their company policy. They can use a risk-based approach, weigh the location of the travel and the vaccination status of the person. And they referred to a recent presentation by Katie Comey that was given to HFAs and AFCs. So they implied a flexibility here that we thought was promising because we know the impact this would have on members. So we sent that out as well, but we did note that what they referenced, the program that they referenced here did not allow those flexibilities. So we again have some unclarity. So then finally, you can move on, Blake. Yesterday, we received the latest response from Katie Comey for MDHHS and the IPRET team. Supposedly, she's speaking for both of them. And now, believe it or not, we are back to the original travel restrictions. Facility policies are only meant to come into play when they are more restrictive than the MDHHS or CDC guidance, which are, pretty much the same. The department did note that untested staff should be quarantined for 14 days. Well, that's not even what the CDC says. The CDC says 10 days if you don't test when you return from travel. And although the original IPRET team response did say that long-term care staff needed to be quarantined for 14 days because they're working with high-risk residents, the MDHHS guidance doesn't really say that. So to be honest with you, at this point, I'm not sure it would do any good to continue these conversations with the state, but we want to point out one thing, that facilities do have the ability to move to contingency and or crisis staffing strategies when needed. And if these policies are impacting the ability to provide care, we suggest that you clearly document your rationale for applying a contingency or crisis strategy, and that you document your policy for those levels of staffing. We do have a meeting coming up with the director of MDHHS on Friday, and part of that discussion will be the lack of clarity and conflicting information about these kinds of guidelines, along with Dalton's discussion related to the HFA-AFC restrictions, and of course the inclusion of independent living in the current quarantine guidance by MDHHS. So we find this extremely messy, and we apologize for the confusion, but this is where we kind of have landed at this point. So let's take some questions about any of that.
Okay, thank you very much, Deanna. Before we get to any questions, I did just want to show everybody really quick. If you head over to the Leading Age MI website, you go ahead and click on events. We do have quite a few programs coming up. This upcoming Thursday, we will have a Housing Matters program, so you can go ahead and register for that. We also have the Assisted Living Conference coming up. That used to be previously called the ALHFA Day. If you were interested in that, that registration is open for that as well. And we also have a Finance and Strategy Day coming up May 13th. So we have 3 good programs coming up, and I would say the next 3 weeks, I believe, is what it is. So if you're interested in any of those, go ahead and register, and we should have more coming shortly. All right, so we do have a couple questions. It looks like one is for Dalton, so I'm just going to ask it anyways. I'm not sure if you'll be able to answer it or not, Deanna, but we will see. Just to clarify, SNF and AL wage increase applies only to CNAs, nurses, and caregivers, not to positions like administrative assistant, medical record scheduler, payroll, housekeeping, dietary. Is this correct?
That is correct. It does only apply to people who provide direct care.
That's what I thought. Okay, thank you. And what are the restrictions, if any, for vaccinated staff who travel?
They don't have to quarantine. They do have, they are suggested to be tested before they go. They should be self-monitoring, but there are no quarantine requirements.
Is it your understanding that the 14-day rule is for long-term care only and not for AFC or HFA?
Well, that's a very complicated question. The reason why is because HFAs and AFCs of a certain size are required to follow the CMS 20-39 NH visitation guidance. And that visitation guidance links to the quarantine and links also to travel guidance. So technically, HFAs and AFCs could be considered to have to adhere to that travel guidance as well. And I would have to, I believe that through my discussions with the state, the idea is that the travel guidance applies to all healthcare kinds of facilities, HFAs and AFCs as well, although I never really directly asked that question. So that's a question that we can ask of the state if I want to talk to them about travel anymore, which I don't, but I can, and see what they say. But I believe it's their intention that it applies all throughout all settings.
Okay. Back for travel. Facilities should follow whatever is the most stringent until clarifications come in, that is.
Well, that's the general rule, yes. I think that with the travel guidance, though, since CMS doesn't have a travel guidance, and at least, you know, we're talking about nursing homes, the CDC recommendations are always, to some degree, they're either used as a national standard or they can be adapted by states. So states have a lot of purview over something like this. The thing is that the state technically at this point is almost 100% in alignment with the CDC guidance, although there lacks some clarity about the 14-day restriction for long-term care staff, although I do have my original response from the IPRAD team, which said that applies to Michigan as well. So haven't gotten a response from Katie Comey at MDHHS about that 14-day piece. And in fact, I think she got a little confused in the last response with what that, the 10 days for staff who come back and don't test versus 14 days for long-term care. And we can ask both those questions again and see what we get. And I think that I'll try and direct it to Katie Comey because she seems to be the major policy person at the state. And when I reach out to other entities, I get very confusing messages, and then we all turn around and we always get back to, okay, what are the real restrictions that the MDHHS is going to do? And pretty much they come from Katie Comey.
Does the travel guidance apply to visitation? If a family member is in town from out of state, not vaccinated, and wants to do an indoor visit, do we restrict them?
Well, that's a very good question. One of the things that's come up, I've noticed on the listservs, is the question of how you're screening your staff, and I would assume your visitors. I'm assuming the screening level for staff, the screening criteria for staff and visitors should be pretty much the same. But there is no actual requirement that I can find, at least in the recent guidance. I tried to go back further, but I didn't have time to do that. That identifies that you should be screening for travel. You should be screening for potential exposures, but it doesn't say anything about travel specifically or where someone's traveled to or when they traveled. And I know that a lot of facilities have put out guidance to their staff, but they haven't necessarily put that in the screening piece. So unless it's in your screening, how do you know? How do you know? And I don't know how you can apply this guidance other than perhaps letting your staff know, but how would you let your visitors know unless you put up a poster or something? I think that would be something that you would make a decision about. I don't see any requirements that you restrict visitors in that respect. So I would think that would be up to your individual facility. There's nothing that I see addressing that in the requirements at all.
What kind of notifications do we need to make to put crisis capacity staffing into place? Contingency capacity staffing depends on shorter quarantine and testing to reduce quarantine, both of which MDHHS has said are not currently options.
I'll have to review that somewhat. I do know that that MDHHS has issued guidance that says do not take some of these shorter options for quarantine, but I don't know that they actually have said that in terms of crisis or contingency level strategies or concerns. I would think that that would be a very dangerous thing for them to do, considering the staffing issues that we have in the state right now. So I'll have to go back and look and see whether or not some of their restrictions about quarantine actually include avoidance of crisis and contingency strategies. I don't remember that being the case, but we can look into it. I could be wrong.
When should the test be conducted for returning unvaccinated staff on return from travel or after 7 days quarantine?
It's within 3 to 5 days after they return from travel.
We had before this update showing rational considered POC antigen testing before each shift worked, that an asymptomatic person in quarantine works during that 14-day quarantine period. With this update, it seems that this would no longer be an option.
I'm going to have to ask you to repeat that a little bit slower, Blake, please.
No, that's fine. We had before this update shown rationale considered POC antigen testing before each shift worked, that an asymptomatic person in quarantine works during that 14-day quarantine period. With this update, it seems that this option would no longer, or it seems that this would no longer be an option. Do you want me to?
I would have to agree.
Okay.
No, I think I would have to agree. I don't believe that that's an option. I'm not sure if that's a standard practice. I think that that might have been a facility policy, but I could be wrong, and it feels like a pretty good policy, really. And it might be something that we could offer to the state. It does seem to me if anyone tests negative on any one given day, that indeed we can trust that they're not at least currently infectious. And that might be something to kind of address this, I think, significant staffing issue that will obviously come into play, or people are not going to be able to travel anyway. It's just hugely problematic. So we will collect these pieces and we will go ahead and get back to the state and offer that as an option. I think it's a pretty good idea, really.
So the initial 3-month time period on vaccinated people and travel is now gone, correct?
I know someone referred to that, I think, in the last webinar. I was not aware of that requirement. I do think that they estimate that vaccinations might be effective for a longer time than that. I've heard 6 months, but I haven't seen anything in terms of guidance about how that would impact the need to quarantine someone for any issues, including travel. I think perhaps we can reach out to the CDC on that one. Or if you are aware of a reference that says that, I would be more than happy to look at that. I'm not aware of it.
Okay. So that looks like that is the last question for now, so we can go ahead and move forward.
Okay. So we do have a few other updates from the CDC this morning to review. This page links to the updated CDC guidance for retirement communities and independent living. So as usual, there's not a lot new on this web page of the CDC issues, but there is a cautionary note about reopening, whatever that might mean to your respective community. I know that everyone is pretty much in different stages of, let's call it, being open. Even though persons are fully vaccinated, the CDC wants to ensure that people know that the general safety precautions should still remain in place. It's not really clear, other than that, what else they may have updated in this linked page. But they do have extensive guidance on maintaining operations through the pandemic, along with a lot of best practices, and members might want to review that. So there is also an updated guidance on wearing masks. And although this is not specific to healthcare, it does provide some good information and educational content for staff. There's also a recent update to two guidance on N95 masks. Basically, they talk about the fact that PPE supplies have pretty much returned to normal. I'm not sure if that's true for everyone or not, but according to the CDC, if they are fully available, healthcare facilities should promptly resume and move back to conventional level practices. We have also included a link here to the NIOSH certified PPE equipment list to identify all those respirators that have been approved. And the second piece I skipped a little bit. There is an update for clinicians on how to treat COVID-19. It came out on the 17th. So the link for that for your clinicians is here as well. So a bit more on N95 use. In recent conversations between CMS and Leading Age, apparently it became known that some states were requiring N95 use for all long-term care staff across the board. And CMS identified in response to that N95 use is really only required for those providing direct care. And it was not intended to be used as a general source control practice. Even when there's an outbreak, you have to be taking care directly of residents in order to need an N95 mask. The only other time when you might consider wearing it is if you're using the mask for extended use and you're going from activity to activity that might not involve direct care activities, in which case you might wear an N95 all day for source control and for direct care activities. But that's the only time they think that anybody who's not doing direct care should be wearing an N95. As we stated a bit earlier, we found the inclusion of independent living in the recent MDHHS quarantine guidance a bit disturbing. And those requirements for quarantine based on the CDC updates for vaccinated persons. The fact that you would have to know whether or not everyone in your facility is vaccinated or unvaccinated, or your ability to apply quarantines and independent living is extremely problematic, and we know that. So we are discussing this issue with MDHHS. Otherwise, this guidance, which applies to all long-term care settings and independent living across the board, that came out from the state, is pretty much consistent with the CMS and CDC requirements for quarantine. The MIOSHA emergency rules have been extended to October 14th. You can find the link for them here. They've not changed. Businesses, as usual, including healthcare facilities, they have to have a COVID response plan, training, screening, notification procedures, etc. And also, it continues the requirement here in Michigan that anyone who can work at home should work at home. CMS did terminate 4 of its waivers for skilled nursing facilities, and these changes are effective on May 10. We do note, and they noted themselves, CMS did, that the 3-day hospitalization waiver is still in effect. And pretty much what they have eliminated are some of the timing issues. The timing of notice to residents before you can transfer discharge them. And this was basically waived so that facilities could cohort patients quickly. Waiver of requirements related to timing of notification of room or roommate changes, again, so that you could cohort quickly. They're also eliminating the waiver of timing to complete certain care plans and to complete and transmit the MDS. And they're changing some of the nurse aid training information. They've not gotten rid of the waiver for nurse aid training and certification. We're going to talk about that in a minute. So CMS is only ending the waivers for timing of these notices for transfers, discharges, and room changes. The related waivers, which continue to allow facilities to transfer, discharge, or change rooms for the sole purpose of cohorting, you can still do that. You just simply have to notify using the same rules that were in place before. I think the essential piece here, the really important piece, is about nurse aid training. This waiver allowed facilities to employ individuals beyond that 4-month period in a nurse aid role, even though they may not have completed the state nurse aid training program. And the person could continue to work under this waiver, and this waiver still is in place, remember, as long as the nursing home ensured that the nurse aide could demonstrate competency in ways needed to care for the residents. So they're not ending this waiver, but they are clarifying how federal regulations can be applied to nurse aides working under this waiver and help them become certified nurse aides. They're recommending that states look at their individual training programs and consider allowing some of the time worked by these nurse aides during the emergency to count towards the 75-hour training requirement. We've not heard anything from Laura about this yet, but it did just happen a few days ago. States still have to ensure that all of the required areas of training are addressed and that any gaps in on-site training are identified, they're identified and they're fulfilled through additional supplemental training. And nurse aides still have to pass the state's competency exam. One of the good things, I think, is that nurse aides will have the full 4-month period starting from the end of the blanket waiver to successfully complete the required training and certification. So the blanket waiver is still in place. The nurse aide certification is still waived right now. And so they'll have 4 months after that waiver goes away, regardless of the amount of time that they work during under the waiver. So although nurse aides do have these 4 months from the end of the waiver to complete the certification and training, CMS strongly encourages the states and nurse aides to complete all training and certification requirements as soon as possible. Lastly, MDHHS issued this notice yesterday about updates to the supplies pathway for EM resource reporting. The mapping resource is linked on the slide. So we assume that the SNFs will be able to use this to figure out how to do their updated reporting for them. We're still waiting for the reporting FAQs to be updated on their website. We've asked for them several times. They keep telling us they're working on them. It would be helpful to have something to refer to when we're talking about reporting, whether or not it's for SNFs or for HFAs and AFCs, but we have not gotten that yet. So, but anyway, there is a new pathway to figure out how to map the EM resource data in this NHSN, and facilities will be notified when the module is updated that aligns directly with the NHSN pathway. And that's all we have today. Any final questions?
All right, thank you, Deanna. I am not seeing any questions right now, but if you do think of anything after this webinar has concluded, as always, you can email safeandcalm@leadingagemi.org, Dalton or Deanna at leadingagemi.org, and we will make sure to get those questions answered for you. Again, just a quick reminder that Deanna will be out of the office starting tomorrow through April 30th. So you can email that safeandcalm@leadingagemi.org if you have any questions, and it goes to multiple people on the team, and we will make sure to get an answer for you. Just another quick thing, a reminder that we will not be holding our Safe and Calm webinar next Wednesday, but we will be doing it the following Wednesday, which will be, I believe, Wednesday, May 5th. So with that, I am still not seeing any questions, so I think we should be all set. So at this point, we'd like to thank Deanna and Dalton, and we would like to thank the 90 members and participants that took time out of their busy schedules to join us for today's webinar. We appreciate everything you guys do each and every day to support your staff and provide quality care to your residents. We are grateful for your continued support, and we are here for you when you need our assistance and resources. With that, I think we will conclude today's Safe and Calm webinar. And as we mentioned, we will see you Wednesday, May 5th. Thank you and have a great day.
Stay safe, everyone.